Welcome to the final part of the Abdominal Injury and Trauma lecture series. 1 in 10 deaths from trauma is due to abdominal injuries. The abdominal area is very vulnerable to injury since there's minimal bony protection for the underlying organs. Abdominal injuries rank third as a cause of traumatic death, preceded only by head and chest injuries. Unrecognised abdominal trauma is a frequent cause of preventable death. The most common mechanism of injury for abdominal injuries is a motor vehicle crash. This can be followed by firearms, stabbings, physical assaults that are associated with penetrating or blunt abdominal trauma. Also, if a patient is struck by a vehicle, as in a pedestrian struck by a vehicle, there's a high incidence of abdominal injuries. Patients presenting from a fall greater than standing height, or if they've experienced significant hypertension or have a history of hypertension at any particular time, it can actually result in lack of oxygen to the organs in the abdominal region. All trauma patients are assessed using a primary survey, and those fulfilling trauma call criteria should receive trauma team activation. One thing to note before we move on to the next slide, however, is that sometimes patients can actually compensate for internal injuries for quite some time, particularly the young. They have a greater ability to compensate for internal injuries, and therefore the signs and symptoms may not actually be present until quite late. Also to note is the presence of significant chest or pelvic injuries may actually also be indicative of the fact that the patient may have associated abdominal injuries. History is important. The mechanism of injury is also very important and provides information on the likely forces that have been involved to actually inflict that particular injury or trauma, and the potential injuries to the underlying structures. Penetrating injuries are usually more overt and dramatic because you actually can see it. You can usually visualize the blood, or if you can actually see they've got something penetrating the abdominal area. However, on the flip side, blunt abdominal trauma is more common. However, it's much more difficult to assess. The spleen and liver are the two most commonly injured organs within the abdominal cavity, despite the fact that they actually have protection from the ribs. There's a number of pre-hospital considerations our paramedic colleagues actually undertake when they actually pick up a patient with any of the high associated risks of injuries we've just already explained, or an abdo injury. So normally they do their primary survey, they treat any abnormalities according to the local protocol before commencing a secondary survey and transferring them to the ED department. They bear in mind that if a patient has a solid organ injury, there is usually overt bleeding and possible hyvolemic shock. For hollow organs, the patient may present signs and symptoms of possible peritonism, which I'll cover a little bit further down the track. Major vessel injury, they usually associate with heavy bleeding and possible extenuation of the patient. So although a full abdominal assessment is not part of the primary survey, evaluation of the abdo as a source of bleeding is an integral part of the circulation aspect of the primary survey. So it doesn't really form part of the primary survey per se. So therefore, you don't move on to the abdo until your actual ABCs are stabilised. The airway, breathing and circulation must be stabilised before you actually move away and move on to abdominal assessment. The vital signs, as we've discussed, be aware of your patient's ability to actually compensate sometimes for quite some periods of time. The assessment is undertaken using the PQRST of pain. You're looking at location and nature of the pain. Diagnostic assistance, which we'll discuss a little bit later, may be necessary to help guide your diagnosis with that as well. You're looking at any associated nausea or vomiting, the patient's position, any associated chills or fever. You're interested in their last bowel movement, the type of the movement, and last food and last fluid is of utmost importance, because if a patient presents with abdominal trauma, then it's the high possibility that they may actually be heading towards surgery. So you need to know that as well. General investigations or interventions that you can actually undertake are that your patient, you'll be monitoring their ABCs. They may need supplementary oxygen. You'll have serial ECGs happening. You'll have them connected up to a monitor. Being a trauma patient, you should always have cannulas, IV cannulas, at least 2 large bore. You'll be drawing bloods for the basic stuff, FBEs, UNEs, LFTs, renal functions, random blood glucose, but you'll also be drawing blood just in case they need some fluid replacement in the form of blood products, so you'll need to know what their cross-match is. Their fluid balance replacements, bloods is often required, and whether or not you use normal saline or colloids will be indicated by your patient's actual condition and any improvement or deterioration and your constant monitoring. And they may or may not need some symptom relief. They may or may not need an indwelling catheter put in to monitor their fluids and things like that. Other specific investigations include an abdominal x-ray. I have it asterisked here because Cameron ETAL purport there's little place for plain radiography of the abdomen in the trauma patient. Abdo-CT is non-invasive and provides precise details of intra-abdominal pathology. However, on the downside, your patient needs to be stabilised before you can actually take them in there. For a focused trauma ultrasound, a relatively new technique which is non-invasive and in some places can actually be done by the bedside, and can be repeated as necessary without being detrimental to the patient. And a laparoscopy, also, as the abdominal cavity cannot be viewed by the naked eye, they may need to be actually taken to surgery for exploratory surgery to see what exactly is actually happening within that abdominal space. There are different evidence-based algorithms that have been developed for the penetrating trauma patient and the blunt trauma patient, and I'm happy to place them on the LMS for you so you can actually see them as well. In the unstable patient with identified abdominal hemorrhage, it's usually stabilisation of the ABCs and then straight to theatre. The less catastrophic injuries, it's usually stabilisation, fluid resus, detailed investigations to determine exactly where and what is actually injured or damaged, and then your treatment will be dictated and care will be dictated from there. However, be prepared for subsequent deterioration and a need for exploratory and reparative surgery. There are several indications for a laparotomy, and they're coming up on your screen now, so you can read those. Hemodynamic instability, any presence of any organs outside the abdominal area which should not be there, any gunshot wounds to the abdo or thorax, because exploratory surgery will be needed to ascertain the pathway of the trajectory and anything it may have damaged in its way. Stab wounds for the same reason as above. Hemodynamic instability despite fluid correction, so your patient is actually still losing fluids and they need to identify from where they're actually losing those particular fluids. Any frank peritonism, any free gas on X-ray, and any ruptured diaphragm as well. Peritonism is actually a symptom complex. It's marked by vomiting, pain and associated shock with inflammation of any of the abdominal viscera regions of where the peritoneum is actually involved. And then the emergent indications for a laparotomy would be a positive FAST. And the FAST was the focused assessment with sonography for trauma, i.e. basically the bedside ultrasound. Pregnant patients that present with abdominal trauma actually pose a number of different issues as well that need to be considered. In Australia and New Zealand, the incidence of abdominal trauma in the pregnant patient is rare, and the vast majority suffer no obstetric complication. Worldwide, the incidence is about 7% of pregnant women that suffer abdominal trauma. So, however, but blunt trauma, even minor, can produce placenta eruption, uterine rupture, uterine contractions associated with premature labour. Any penetrating trauma, the outcome depends on the locality of the stab or missile wound. Penetrating wounds to the upper abdo region can also cause quite complex injuries. Fetal mortality can be up to 70% if it's a direct missile injury. However, priority in the management of the pregnant patient who has sustained a major trauma must always be maternal stabilisation. Disposition for the patient who has presented with abdominal trauma. It may be difficult in the less seriously injured patient or for those with suspected abdominal injury. Decisions can be a lot harder. Every patient suspected of or at risk of intra-abdominal injury should be admitted for observation, serial examinations, ideally by the same individual, or documented quite thoroughly as well. Injuries to the bowel wall or intestinal blood supply may not be evident on initial clinical examination or investigation and can actually take up to 24 hours to actually declare themselves. So I've presented you with a lot of information that you might need to have a look at, go back over and review in your books and things like that as well. However, what I'd like to finish up with now would be a quick case study, and it's on Mr. F. Now, Mr. F is 70. He presents to the GP with left-sided abdominal flank pain, of which he's actually had for 2 days. He's got a past history of diabetes, a mild aortic stenosis, a coronary bypass surgery, and has a history of AF as well. He reports tiredness, nocturia, urgency, and frequency, but no dysuria. On examination, he has mild left renal angle tenderness. On his full ward test, he shows leukocytes, protein, blood, and glucose. He's afebrile, and his blood pressure is 156 on 90 millimeters of mercury. So what's wrong with Mr. F? Your first thought may be he's got a urinary tract infection. The GP thought so, so he ordered him trimethoprim with a review in 3 days, if no better. In the next 2 days, the pain increases and the son takes Mr. F back to the GP. He had been seen the day before at a home visit and given some non-steroidal anti-inflammatory suppositories for the renal colic. But now the pain was becoming more widespread and extending into the suprapubic area and the left hypochondriac region. Mr. F's BP was now reading 140 on 80, and he complains of left shoulder pain when laying down. Mr. F is now suspected of having an acute abdomen, and the GP sends the patient to the ED. However, the patient refused, saying it will be okay. The patient deteriorated rapidly over the next day and was admitted via ambulance to the local ED, and was admitted as a matter of urgency. The surgical team assessed the patient and found an enlarged spleen. It was actually found to be ruptured on abdo CT. Mr. F underwent an emergency splenectomy. Splenic ruptures are usually associated with trauma, and spontaneous rupture is rare. However, there was a couple of flags here. Be aware of the left upper quadrant pain that refers to the left shoulder pain. As you already know, this is known as Kerr's sign, and hypertension. Splenectomy patients need to be monitored for progressive deterioration, and post-op complications include infection, hemorrhage, sepsis, subdiaphragmatic abscess, and fistula. There's a condition known as OPSS, overwhelming post-splenectomy sepsis. It's a late complication, and complications of OPSS are adrenal insufficiency and DIC as well, with associated with a high mortality rate within a year of surgery. However, Mr. F had an uneventful recovery and recovered quite nicely, and the purpose of that case study was to basically point out the fact that the first diagnosis or your first inclination would be to actually think of a urinary tract infection. However, it wasn't a urinary tract infection. So the key things to take home for there is to do a thorough assessment of your patient, watch for any deterioration, monitor any improvement, and if you have any questions or queries, these are the references that have been used in production of these lecture series, and I can be contacted any time on my email address. Thank you.